actually talk only about technical tricks and my experience in the 30 years as I'm using the transosseous repair. My first connection on with rotator cuff repair was through a visit to Dr. Neer in 1981. He told me that the golden standard is the open rotator cuff transosseous tendon repair. In 1990, I tried to use an anchor for the arthroscopic repair. At that time, it was only a single repair technique, but I was faced with problems which I thought I can solve it in another manner. So I said, I will try to do the transosseous repair arthroscopically using a technique, and that took me about 1 year of trials. Then we finished with the giant needle technique of transosseous repair. It is a technique using a special needle through the skin, through the tendon, and through the bone, and out again through the skin. The instruments used are a giant needle and a strong needle holder, sometimes also a suture puller, and a so-called suture catcher, and an owl. The positioning is very important. The patient is in a sitting position with the arm hanging in order to push the needle with gravity. A subacromial decompression is done for all cases. I usually decompress the subacromial space to be 12 millimeter, as my colleague said before. First, we do remove the periosteum from the footprint area, and then with an acromializer make a bleeding surface. After that, we go with an owl inside the joint, and I make a hole at the junction to the cartilaginous head. Then the needle is passed through the skin, through the tendon, and then pushed in the hole made before. Then it is stepwise pushed inside the joint, inside the bone, and then also pulled out in a stepwise manner while holding the elbow with my left hand. The two ends of the suture are pulled out through the instrumentation portal. A sliding knot is made and pushed with a concave knot pusher inside the joint to fix the rotator cuff. Sometimes I use the chop needle puller, passing it through the skin in the subacromial space, and then through the tendon, and pull the suture from its entry in the bone through the tendon. I can also use the chop needle catcher and puller to place a suture in the soft tissue. In the partial tear, I usually detect the tear by using the back of my shaver and feel the hole in the tendon. Then with a hook, arthroscopic hook, I try to perforate it. If I succeed, so I have to make a repair. The repair is done by removing the damaged tissue and suturing the rest of the tendon with transosseous repair. The same thing is done for pasta lesion. And in case of supraspinatus full lesion, that's what we call, because we found that at the end of the supraspinatus, sometimes there is like a ballooning or a weak area with no tear, no partial tear. So we cut this bad tissue, and the histology showed that there's increased fibrosis in it. What is the reason? We have to know, but we remove it and then we do a reefing of the tendon. In small and medium-sized tear, we do the standard transosseous arthroscopic repair with a giant needle and also an end-to-end repair. If you have a U-shaped repair, it's like we close an end-to-end and make the tear smaller and then do the transosseous repair. With an L-type repair, we first pull the tendon to the place where it used to be and see if it is possible. Then we put the suture in this place and pull the suture with a chop puller through the tendon and tie the tendon and then do the rest of the transosseous repair. Sometimes the biceps tendon will be tenodized laterally in case of large tears or massive tears and suture the remainder of the tendons on it. In case of Erb's palsy, we have sometimes a redundant totally of the supraspinatus through superior migration of the head. So besides the decompression and resection of the protrused greater part of the tuberosity, reefing of the tendon is done. This reefing is also using the giant needle and chop needle puller. We make a T-shaped incision on the tendon, and then we make a cruciate repair by suturing above each other. Here is with water inflow, you see the tendon is bulging, and after repair, there is no bulge of the tendon. The infraspinatus, the same thing. We pull the infraspinatus as much as possible upwards to see where it will be. And then we place a suture using a giant needle. And then with a chop needle puller, as here we go through the tendon and pull the suture through the tendon and then tie it to the tendon. We can make a more fixation with a suture wire technique to make a mattress suture added to it. In the subscapularis tear, also in the same manner, we place first the suture upwards, and then with a chop needle, we pull the suture through the tendon and tie the subscapularis upwards. This is how we do this mattress suture technique with the wire. The biceps tenodesis is done using the giant needle transosseous fixation by making a raw bleeding area on the tuberosity and the sulcus, and then suturing the tendon to this area, and after that, cut the remainder of the biceps inside the joint, or use the remainder for reconstruction of the remainder of the rotator cuff in cases of large rotator cuff tears. In case of a bicep with distal displacement of the tendon, make a small incision down and then pull the stump of the biceps tendon, put a suture in it, and pass through the arthroscopy portal. We pass an arthroscopy grasper and grasp and pull the sutures up to get the tendon in the sulcus inside the joint, and then we suture it with the giant needle transosseous fixation. The knot I use for repair of the tendon is the giant knot. It is a sliding self-locking knot. Make the knot outside and push it inside the joint with a concave knot pusher. And then after placing it, we pull on the loop and the knot will be blocked. Basic principle for massive tears: manipulation under anesthesia, superior capsule and labral release, arthroscopic capsulotomy, and rotator interval release. Here we see the upper part, superior capsule resection and loosening of adhesions, and then we pull the tendon to try to bring it to the footprint area. Synthetic patches are talked about recently in many places. I just want to say my experience of this way of technique in the 80s. In the 80s, we used to use the fasciolata or the Kennedy lat and other synthetic material to cover the defect on the supraspinatus. But it all failed. The reason why was that When we cover the PSA, it is 6 centimeter. Normally, with active elevation, this will be 4 centimeter because of the contraction of the muscle and tendon. Now, if you place it with a non-dynamic contractible tissue, so the head will migrate superiorly and cause superior migration because the distance will remain the same. And that was the problem. We did a late study on large and massive rotator cuff tear. We reviewed 55 cases from 97 operation with an average follow-up of about 15 years. The patients were average age 54 at surgery and at 69 at follow-up. Range of motion and strength was examined as well as the sonographic evaluation. The results, about 17% still had good and excellent result. 13% has unsatisfactory results. The deterioration with time was presented by 15% of the cases, but the patient satisfaction was approximately similar in early results and late results. Revision of suture anchor repair. This challenge is mainly how to remove the anchor. We find that the best way is using an awl and make space around the anchor, and then with a clamp, we remove the anchor. Afterwards, we repair the cuff by end-to-end suture, and then a transosseous repair, putting the sutures in the sound bone area between the holes. The rehabilitation, 6 weeks passive, either the patient is in abduction brace with a large tear or a small tear with sling. Then another 6 weeks of stretching and active self-assisted exercises, followed by vigorous stretching and strengthening exercises for 4 weeks. We have a special strengthening program for athletes. Full activity is usually reached at 4 to 6 months. In conclusion, important for the giant needle transosseous fixation is the positioning of the patient, doing a subacromial space, preoperative good planning, good mobilization, identify a tear pattern for anatomic repair, and use a good solid tying knots for security. Thank you very much for your attention.